under a physician's protocol. And so most of the bill that's in front of you as you flip through it really just involves striking the words "and influenza" or influenza at various places, because we're trying to say that that system is working in Georgia, it is working for Georgians, and therefore we want to expand it. So most of what you see in terms of technically through the bill is just taking it from what applies today to the flu vaccine and making it apply to all vaccines. And the exceptions to that, if you will look on page 2, line 43 and 44, we have excluded human papillomavirus. A lot of people call that HPV. Otherwise, it is all of the recommended vaccines or approved vaccines by the Centers for Disease Control. These are the vaccines that are appropriate for those of us living in the United States. Just to refresh everybody's recollection about current law, we require a physician within the specific health district of the pharmacy administering vaccines. That is to say, Georgia's broken up into health districts, and a physician that lives in that health district must approve a protocol to be used by the individual pharmacy administering flu vaccine. That would be a part of the proposal that we're bringing to you today. A couple of reasons, I guess, the bill for me is meaningful. Number one is access to health care, and number two is cost of health care. Access, on the access side, a lot of parts of rural Georgia, certainly accessing a physician's office is more difficult at times than accessing a pharmacy, so that those that are due or appropriate for vaccination have an easier time of getting to a pharmacist's location to receive whatever appropriate care they can get. And then on the cost side, what we know is that the cost of administering vaccines in a pharmacy setting is less expensive to the individual vaccinated. It's less expensive to the insurer. The best example is in terms of hard data out there, that TRICARE, which of course many of you are familiar with, that insures our military personnel and retired military personnel and their dependents and families. In August of last year, TRICARE indicated that in all states where this is permissible, where pharmacists can administer vaccines, they would move to a $0 copay for all of their covered lives who are getting in a pharmacy setting. In the next 6 months, they administered about $289,000 worth of vaccines in a pharmacy setting. Those same vaccines, and remember that's zero cost copay to the plan participant, but to the plan $289,000. Those same vaccines, if they had been administered under the medical plan as opposed to the pharmacy plan for TRICARE, would have been $1.8 million. So it's over an 83% savings to TRICARE's over $1.5 million that they saved in 6 months in the 29 states that do allow this, which brings me to the last piece, that this is not plowing new ground. As the chairman has pointed out to me, and rightfully so, I appreciate her very enlightening conversation with me, and I know that this is an issue that she's passionate about, and passionate about patient care in Georgia, as I hope we all are. Just because your neighbor or your friends go jump off a cliff, your mom always told you don't have to. And I certainly am not at all suggesting to this committee or to my neighbors in Georgia that just because others do it, that we should. But what I would say is that the fact that 29 states already do this is a good indication that it's being tried, it's being done well, it's being done without harm to patients across the country. And about 20, I believe 4 of those are more liberal than our proposal here today in terms of what they allow and at what ages they allow. One thing to quickly point out about the bill, we have changed it to apply only to those being vaccinated 19 and over. Pediatricians brought us what I consider to be pretty valid concerns about administering vaccines to minors, particularly in terms of interactions and as they grow and develop. And that was something that seemed to be appropriate to make sure that a pediatrician is administering that at the pediatrician's office, tracking those charts. Most of these vaccines that we give to adults are not annual in nature. Oftentimes we will hear that medical home is implicated by this provision. These are not typically annual vaccines. In fact, the most common annual vaccine is influenza, and we do already allow it to be given in a pharmacy setting. As for the others that aren't annual in nature, as a health plan administrator myself, we're a self-funded plan at home, we do encourage medical home, but we certainly encourage all of our plan participants to have an annual well visit and not less frequently than annually. That's part of what we encourage, and we think that addresses the medical home. All of the vaccinations are uploaded into a database which is accessible by physicians and pharmacists alike, which allows the physician to immediately know if their patient has taken any vaccine, or immediately, as soon as it's uploaded into the database, know that their patient has taken a vaccine. And certainly, to the extent all of our Georgians, but some elderly Georgians often have multiple physicians that they're treating them, but most Georgians have a singular pharmacy. Not all, but most Georgians have a singular pharmacy where they fill, such that that's a good clearinghouse for if folks have drug interactions. They may not tell their general practitioner. They may forget. They do that quite often, to tell them what all they're taking, and they may have a specialist that they're receiving a prescription from. But when they go to their pharmacist, to the extent more folks have a single pharmacist than have a single doctor, actually, in our older Georgians, there's a single clearinghouse. But I've talked probably longer than I should, Madam Chair, and I know it's late, the hour's late, and there's other people wanting to speak. I would gladly welcome questions about Senate Bill 288 and appreciate the opportunity.
Okay, we'll be taking questions, but I must say, Senator Bethel, obviously you live in a rural part of our state and don't live in the metro Atlanta area where, and I know your wife is a small retail pharmacist, and where the pharmacist changes every time we go, and many of them can't speak English very well, and having your own pharmacist is highly unlikely. So come down and spend some time with us here in Atlanta.
Well,
okay.
I appreciate the chair's point.
I have some questions. Turn on my mic on. 87.
All right, Representative Reinders.
Thank you. Thank you, Senator. These are kind of some technical questions that I just don't understand, and I appreciate you giving a little leeway in answering for me. On line 27.
Yes, sir.
What does regularly employed mean?
Let me make sure I'm reading the, okay. I'm not sure that that's a defined term, Representative, so it's not defined in this act. I mean, generally speaking, regular employment in Georgia is 35 hours. I mean, in other parts of the code, that would be 35 hours a week. So that would be a full-time employee. It's not, we have not defined it in this case.
You don't see that to be potentially a problem or anything then?
Well, I think that if you talk about a nurse who is a registered professional nurse, and I would imagine that this, I would think that regularly employed would mean other than just on a contract basis for the purpose of giving vaccinations. It would be an employee, but we have the assurance that it's a registered professional nurse.
Thank you so much. In line 33, physician means an individual licensed to practice medicine and surgery?
Yes.
So we don't have any physicians that don't practice surgery?
I don't know that we have doctors that are licensed to practice medicine but not surgery.
That's the standard way of saying it.
That's a standard way of saying it, because I would hate for someone to be in a situation where they couldn't do something because they haven't performed surgery in 5 years.
I think the license to practice medicine in Georgia is.
Okay. And then finally, if I may, Madam Chairwoman, I don't have the code section in front of me. I don't know what a pharmacy intern is. So can anybody explain that to me?
I'm sure Representative Harden can. Representative Harden?
No, go ahead.
A pharmacy intern would generally be someone now, actually, I guess in their fourth year of pharmacy school, since we only do doctor of pharmacy now in Georgia. We don't do the master's anymore. So they would be in their fourth year of pharmacy school, generally their sixth or eighth year of college, and they would be interning pursuant to their educational program.
So the person that's, I don't know, the pharmacy technician from the local technical school can't be given those shots?
They would not be a pharmacy intern, no, sir.
Thank you so much.
Okay. Representative Henson, put your button, Dr. Maddox. Representative Henson.
Thank you. Thank you for bringing this bill. I have a question or two here. We'll go back to line 27, where you say regularly employed by a physician. I guess it means not someone who just comes in like the Clear Blue and isn't regular, because you could have someone part-time who's still a regular employee that's only working 20 hours a week.
we have specifically, I mean, it doesn't say regular full-time employee.
Right.
So I would imagine that someone who is regularly employed at that physician's office and a registered nurse would be able.
But my real concern on this bill will go to your vaccine, and I forgot where you said it was that you took out the HPV, line 44.
Yes, ma'am.
I would like to have an amendment put into this bill that says the term vaccine shall not include the vaccine for human papillomavirus and rabies. Because I have a real concern. If anybody needs the rabies, they need medical care, and they should not be going to a pharmacist as opposed to a medical doctor. I mean, I know that that was taken from other states, but that does not belong here. And it is on the list that was handed to me from the pharmacy folks, that is included, the different vaccines. And rabies is included in it, and I don't feel it should be, and I much would like to see it removed along with that, so that be added on line 44. And I'm sorry to do an amendment to your bill, but I feel very strongly about that.
No, I think that the point is well taken. I would, I'm not sure that is, I will let others who are interested in the issue speak to it. I would point out that all of the vaccinations have to be done pursuant to a physician's protocol. In other words, anything that would be covered, a licensed physician would have to sign off on.
I understand exactly what you're saying, but rabies for people, and we always think of rabies shots for animals, and that's a one-time shot, and I don't know any pharmacists that are wanting to do the vaccines for animals. But you get to an adult who might be bitten by a rabid animal, and you've got a series of shots. They're in the stomach. It's a totally, completely different situation, and I don't feel that it should be done in a pharmacy. I think about the pharmacies I go to, and the fact that, there is no place. I mean, it's not in your arm.
I'm not arguing. I mean, that sounds appropriate to me. I don't know that a physician would sign off on a protocol for a rabies vaccine in a pharmacy in the first place. But if you feel that's appropriate, you won't hurt my feelings, is what I'm saying by that suggestion. And I do think that we also require positive rabies exposure to be reported to the county health department in Georgia. I think that would be a requirement for any health care question. But I'm seeing some nods, but I can't quote you chapter and verse, but I believe that's a legal requirement.
Okay. Representative Morgan?
Thank you, Senator. This has caused quite a discussion over the last couple of weeks, and so I just had a question about the medical home issue. As I've been looking at this and talking to folks in the field, my biggest concern is if you have adults who don't have a medical home or have one and are choosing to go and get a vaccine at a pharmacy, how do you respond to, if that is the only time they're going to the doctor, then they are not going to a medical home? And then my second question is, how does a pharmacist know that something in a vaccine is not going to have some adverse medical reaction without knowing the medical history of a patient that they are administering this to? And again, it goes back to having a medical home and having a relationship with a doctor.
Yes. Representative, I appreciate the question, Representative Morgan, and I apologize. I try to keep track of who's where when. I did talk a little bit about that, but I'm going to try and not repeat too much what I said
and I'm
earlier.
Sorry, I
but
was
no,
late.
I don't want to take the committee's time unnecessarily. On the medical home issue, I would note that the most frequently administered annual vaccine in Georgia is the flu vaccine. We already allow it to be administered in a pharmacy setting. So most of these vaccines are not annual in nature. So we encourage at least an annual well visit with the physician for good health care practice. And so if they're only going when they get their vaccines, that's a bad thing. We want people to go more frequently than that. And to the extent that folks have a medical home, we hope that their plan, like most plans in Georgia actually now, cover an annual well visit, but most do not cover 100% vaccination. Whereas we talked about with TRICARE and others that are following suit because of the cost savings associated with administering vaccines in a pharmacy setting, are moving to a $0 copay. It would be unfortunate if an individual chose not to go to their doctor because they couldn't afford a vaccine when we deprived them of the opportunity to go to a pharmacy setting and get the vaccine at no charge to them at the point of transaction. So I am for making sure that we get care to the patients that's appropriate. A physician has to approve that. Also, when a pharmacist administers a vaccine, they download or upload, I don't know how that works all the time, but they add to a database a record of that vaccination. Physicians do the same thing, so that the pharmacist can see, oh, well, you already got this vaccine at your doctor's office, and vice versa. The physician could see that in the other case, so that the information is transparent to all healthcare providers. As far as the medical home in terms of drug interaction, what I would mention is that that's the nature of prescription, administration of prescription drugs anyway, in that when you go to the pharmacist, generally speaking, and to the chairman's point earlier about not having the same individual pharmacist every time, I find that unfortunate. And I do live in a place where I see the same pharmacist. I hate that Georgians don't have that experience, because but just one. But the pharmacist, most Georgians do go to a singular pharmacy, not necessarily the same pharmacist every time, such that even if they're going to a specialist, or they have a general practitioner, or they have OBGYN, or various different physicians, and they're all prescribing, most Georgians actually go to a singular pharmacy. And so the records are there in one place, and I would suggest that in as much as there is risk of the general practitioner not knowing what's going on, there's a substantial risk when a general practitioner doesn't know that you're also going to another physician. And unfortunately, that happens in pharmacy settings, it happens in doctor's offices on a regular basis that people don't share. But a pharmacist has all of it in the computer in front of them, what you're getting filled from every source. So I'm a big medical home supporter. I mean, I believe that that is the appropriate pathway for us. But the fact that most of these are not annual in nature, I think that it's somewhat, if we're saying that that's when people go to the physician, then we're surrendering too early. Folks should be going to their physician for an annual well visit, and that should be covered by their plan. When they can get a vaccine that's at a cheaper cost to them, and at a cheaper cost to their health plan, and at a cheaper cost to Georgia to the extent they're on a taxpayer subsidized plan, they ought to be able to go. And remember, it's governed by two things. One, CDC guidelines, because no insurer, I promise you this, I've lived in this world, no insurer is going to approve a prescription for a vaccine or the vaccine being submitted when it's inappropriate. In other words, you've had one within the last 2 years and it's only every 2 years. You've had one in the last 3 years, it's only 3 years. They just won't do it. So you're going to pay the full cost of that, and people aren't going to pay the full cost of the vaccine at the retail transaction. And it's governed by a physician's protocol. It may not be their physician that they see on a regular basis, their GP, but it is a physician's protocol who's saying, you must take this medical history to be able to administer this vaccine. You have to ask the patient if they've done this. And I appreciate the caution that we all exercise in dealing with pharmacists and dealing with folks, but these are licensed professionals by the state. These are not the farm techs that are administering the vaccine. These are licensed professionals by the state of Georgia. And I would offer that in a lot of physicians' offices, it's not generally the physician who's administering the vaccine, it's staff. And that's appropriate too, as long as they have trust and confidence there. But I mean, yes, I am sleeping with a physician, but, or a pharmacist, excuse me.
Oh,
Get that right.
so you're sleeping with a
Golly, it's
pharmacist that
getting,
wants to
is
play
it
a
after 6
physician?
yet? It's after 6 yet.
I
But,
think you told me your wife didn't really want to do this.
yeah, no, yeah, for public disclosure's sake, my pharmacist wife does not really like this bill because she says, I don't really want to give more injections than I already am, but that's beside the point of, I mean, that's a choice she can make as a professional, not to participate.
Okay, Representative Maddox.
Senator Bethel, I don't have any opposition to the physician making the vaccine protocol, but occasionally you may have a anaphylactoid reaction.
Yes.
Do they have access then to epinephrine or something to treat this with, or do they have to call a physician? You know, sometimes it can be real death-threatening, and it got to happen pretty quick.
Well, I appreciate the question, Representative Maddox, and it's a valid concern. What I would say is your neighbor next to you may be able to help me, but I know of no pharmacy in Georgia that doesn't have EpiPens on site. I know of no pharmacist in Georgia that has not received first aid training. And I do know that there are a number of times when vaccines are given in county health departments and there's no physician anywhere on site. And I also know that we've been given flu vaccines in Georgia since 2009. And to my knowledge, you're just as likely to have anaphylactic shock from the constituent components of the flu vaccine as any other vaccine, as far as I know. Nobody's shown me any data otherwise. That it's when you get a foreign substance in your body, a certain portion of the population gets it. But we've had no trouble with that in Georgia nor any other state that I've been made aware of at all.
If you did have one,
They can
the nurse and the pharmacist can use some epinephrine or whatever. You
Yes,
need.
sir.
Okay.
Yes, sir.
Okay, Dr. Watson.
Thank you, Madam Chairwoman. Senator, I just, I got a lot of issues with that. I got a lot of issues with with your assumptions that cost and access are easier through a pharmacy. I would be willing to say that I think that access, is good in our rural areas. I think that public health departments who administer vaccines are there. We have counties, almost all counties are covered by public health departments, and if not districts. So I don't think that the access issue is an issue at all. And I'd also say that, cost, you're citing that TRICARE has said that pharmacists can do it by zero copay. And if that's your only cost, improvement, then why can't TRICARE give zero copays for physicians' offices? And you know that, interestingly, I don't charge any more for vaccines in my office than the pharmacy does for his influenza, or any more than the health department does. That is a supply and demand aspect of that. It is part of the visit. And to say in this day and time when we're doing medical homes and accountable care organizations that your pharmacist is the primary care person that they're seeing, I think is a shame. I think that's terrible. To say that your primary care physician is not the person that should be leading the team there, I just have a real difficult time with that. When I give, to give this, I think you should be encouraging patients to come in to see their physician to get their flu shot. And you're right, well patient visits are paid for by some insurance companies, but most do not. Medicare has just started that, and I hope others will. And I think that's a wonderful thing. But it is remarkable how many patients do not come to their physician, do not come to their primary care physicians, to get routine screening things, routine colonoscopies, women getting, pap smears, which hopefully are getting less in the future, just the routine mammograms, and so forth. It is difficult to get patients to come in and do that. Many times we wait until we have a problem. So I think we should be encouraging patients to come in to see their primary care physician. So I think through accountable care organizations, which is a wave of the future, which is the medical home, I think we should not be doing this. I think we should be encouraging patients to come into their physician's office. Why did we let influenza vaccination come into existence to begin with? Certainly I was not here. My understanding is that it was a public health issue. And I think it is a public health issue. It is something that should be done, on a yearly basis. But do you know the percentage of patients that actually get influenza now, even with pharmacists and even with drive-by public health times? It's 43% of our population. And that's not good. Now, I'll tell you, I'm not against influenza vaccination in pharmacies. I think that's good. Now, if you have an anaphylactic reaction to the eggs in that, or if there's some other byproduct that you're allergic to, you know, who do you feel more comfortable with? The protocol, the EpiPen, the protocol that you're giving as a pharmacist, that you've given in your residency and training? Give me a break. I mean, I will tell you, I don't administer epinephrine, very often, and when I do, you got to take it seriously. But there are very primary allergic reactions that can happen. Most physicians have ACLS protocol. I don't know any pharmacist that has that. You're not qualified to have that. And the secondary reactions that I treat relating to influenza vaccination. I mean, I treat secondary reactions, all the time. Now, does that drive up cost of health care? Yes. Should you be treating that? I don't know. Go to medical school. So I just have a lot of issues relating to that. I certainly understand, access is difficult. And, primary care, we're 41st in the state of Georgia. We should be having more primary care physicians, no doubt about it. Actually, we're 41st in all physicians. The whole idea of this encroaching and scope of practice, I understand it, and I hate to be cynical, but Walmart did the $4 prescription. It hurt other pharmacies. I think y'all are bouncing back, and I'm glad you are, because I do think there need to be local pharmacies, and I think that's a good thing. And I think the bill that I'm sponsoring, in the House for y'all, whether you will allow y'all to mail the prescriptions, I think that's good. But the reason Walmart did that, it was not out of the goodness of their heart that they did $4 prescriptions. No, it's because, as the Wall Street Journal reported when they did it, and this was about 4 years ago that they showed that, is $78 that they actually make on that person walking in the door. They do the $4 prescription, and then it's $78 while they wait for their prescription. I get the warm and fuzzies about that, but I don't get the feeling that this is about the patient. I'm sorry to go off on the diatribe, and I apologize for that. It had just sort of frustration had built up there. But you can tell I feel passionately about it. And I think we got to put the patient first. And, from my perspective, and I'll sit down and I apologize for ranting, but if you don't put the patient first, which is in my opinion, you got to encourage patients to come in and see their physician. They just don't do that on a regular basis. I agree with you. We should be doing that. The medical home and accountable care organizations are good. I think this is a step in the opposite direction.
Thank you, Doctor. I tried to take notes. And first of all, if I may take the liberty, don't ever apologize to me for being passionate. I mean, I wish we did that more. I appreciate your love for your profession and your love for patients. I mean, that's how we ought to talk to one another around here. And the fact of the matter is, there's 10 million people that want us to make good decisions, and we ought to make them with our heads and our hearts. So that's fine with me. I do want to try and address the things I heard. I was trying to scribble and make notes. I do recognize that we do have health departments, and we do, of course, administer vaccines in those settings, often not under the administration of a physician who's present. That being said, there are parts of Georgia where making the health department is further than making the pharmacy. Now, is that an all-access issue? No, I mean, I'm not trying to say that's the only basis of it. On the cost side, I did want to make sure I was at least clear. It's not the $0 copay that makes the savings for TRICARE. It's that it costs less in their pharmacy plan. In other words, what is charged by the pharmacy is lower than what is charged in a physician's side. And so it's about 83% savings to TRICARE, and that's without including a copay. And that's just the raw dollars that they're seeing in terms of savings. So I certainly understand that the market drives the cost as far as what you charge in an office or what you charge in another setting. today, there's not a market. There's a single source market, and in states where there is a market, it costs less to do it in a pharmacy setting, and so there's a savings there. If I at all insinuated that I think a pharmacist is your primary care healthcare provider, I apologize for that, because I don't believe that. I don't support that model. I think that physicians are your medical home and should be your medical home, and we try to drive that in our health plan that I administer and otherwise. And I made a note here, and I'm trying to read it, and I can't read it, so I apologize. There was something I was trying to answer you, and I apologize, Doctor. I cannot read my own scribble as I was trying to get through the list, but I do appreciate your passion for the issue, and I do think we should be sending folks to their primary care physician. I don't think that relying on regularly scheduled vaccines is probably the most efficient way to drive that patient relationship with their doctor.
Representative Watson, you had a follow-up?
Well, just the follow-up is that, what drives the cost of health care? The healthcare system, unfortunately, is less than free enterprise because of what has happened in the past with related regulations and who pays. The insurance companies pay for the vaccines mostly, and so I think that's a little bit, the numbers there that TRICARE may be saying the savings is not necessarily, is that rigged? Because, they're paying for it.
It's costing them $300,000 for the same vaccine as opposed to what would equivalent to be $1.8 million under their medical plan. That's just approved charges and the equivalent if it had been in the medical plan.
So they're going to pay you less than they're going to pay the physician?
Yes.
But you know what? Unfortunately, the insurance companies decide that.
I understand. A pharmacist can't collect them.
Just one follow-up, and I'll be quiet here for a second. The database that you entered into, I've been practicing medicine for 30 years, and I swear I've never looked at a database of where they've gotten influenza vaccination. And, we're judged on the accountable care organizations and the medical home of keeping up with the flow sheet of what vaccinations patients have had and so forth.
Yes.
I'm just not aware of that database.
I would expect that those that are signed up will be more familiar than I, and I don't want to speak about something I only know generally about.
Okay. Representative Watson, I have a question for you. When a patient comes in and they're asking for their pneumonia vaccine, is that the only thing that you refer to? Or if they haven't been in for a mammogram or they haven't done, is that something that you go over before you give them?
In the medical home and accountable care organizations, the way we're judged, and you know what, and this is right, this is what we've been doing in our electronic health record for the past 7 years that I've been on it. We look at a flow sheet, and we look at the mammograms, screening colonoscopies, PSAs, rectal exams, pelvic exams, and so forth. And we also look at vaccination, pneumococcal vaccination, influenza vaccination that year. We look at tetanus, we look at HPV, and the whole works. We go down that list of doing that. And yes, it is onerous, but it's the right thing to do. So it's a piece of the puzzle.
So what I'm asking, though, and I don't have a medical home, but I think I found a doctor in the last couple of days I'm going to ask to take me for a medical home. Because right now my husband doesn't want to treat me and I get poor medical care. But in a medical home situation, when you go to a normal GP that's not your husband, if I came to you asking for something because I was going out of the country and I wanted a vaccination, would you then look at my chart? And if I hadn't gotten a mammogram or I hadn't gotten a colonoscopy in a certain town before you gave me that prescription, would you also bring up the lack of the other and try to get me to schedule it?
Yeah, absolutely. We look at, if you come in for a cold, or you come in for some other reason, you hadn't been there for a while, we update that. And it's important, especially, in chronic illness, whether it's heart failure, high blood pressure, stroke, but, especially diabetes. We look at that. When was your last hemoglobin A1C? Has that been more than 90 days? And those are the things that gauge us, that we get judged on. And those are the things that gauge us in how good quality care that we give to the patient. And anything we can do to get the patients into the office is important. And
Okay.
that is certainly a piece of the puzzle, absolutely.
Okay, you raised a question, and I will answer it before I go into Representative Pack. You said, and there are several new members here that were not here when we did the influenza. I was part of the negotiations on that bill, and we, at the time, and I'm forgetting which strain it was, there was the possibility of having a strain, which was it? H1N1, and the country was in a panic, and so the governor felt like we might be facing an epidemic, and so at that time they came and asked the pharmacists to ask that they be allowed to give them. At the time, they agreed they weren't coming back for anything, and I think a year later, or maybe 2 years later, they came back and asked for the flu mist, and feeling that it might be safer and easier to administer, and people might be, then that was granted here again, and the agreement was saying that they would not ask for more. And that is the history on how we got to give influenza. And some of the older members that were here, I think you will remember that, but I was on the negotiations on that. So that, to bring you up about how it appeared, and it was because the country was facing an epidemic, a possible epidemic. Representative Pack.
Thank you, Madam Chairwoman. Thank you, Dr. Watson. Remind me I have to go see my doctor. A question related to line 39 is the existing law, and as I read this bill, excluding from definition of vaccine is anybody younger than 13 and older than 49 years of age. Am I right about that, Senator?
Well, it excludes it under the definition for this code section. That's correct.
And so my question actually goes to then line 200 and, let me see over here, 202 down to 204. Maybe just a little inconsistency, because I think the vaccine protocol agreement that's previously defined, this section also seeks to limit who could get vaccines. And what I see is it says age of 19 on the line 202.
Yes.
So they can't give to somebody under age of 19 without an individual prescription. And then anyone under the age of 18, you have to have parental consent. In addition to that, the question is, what about somebody who's 18?
They would not be able to receive a vaccine under this code section as the bill stands before you today.
Okay, so that's the only group that really doesn't need
No,
dealing.
they would be able to receive a vaccine with a prescription at a pharmacy, but they would be an adult and wouldn't need a parent's. Yeah, they would be able to get the vaccine if they had a prescription. Their prescription would not have to be combined with a parental consent.
Okay. Yeah, the question is, why is it 19 instead of 18? I guess that's...
The pediatricians, in raising their concerns, brought to light that the general final pediatrician visit in Georgia happens when an individual is 18. That's sort of the clearinghouse visit. That may be when you're, if you are going to college, it may be when you get your physical in preparation for going to college. If you're not going to college, if you're going off into the military, the last time you get to see a doctor who's nice to you for the next few years is that last visit when you're 18. They raised the issue, and one of the primary concerns their representative was unfortunately, pediatricians reported that there's a pretty high rate of dishonesty among pregnant teenagers, and giving a vaccine to a young lady who is pregnant can have very catastrophic outcomes. And so they were very interested in making sure that that was a physician looking in the eye of a patient that they had known and seen for years. And certainly that's, to me, an understandable concern.
Is that it, Representative? I mean, you have another, Representative Pack, that's it. Representative Henson.
Thank you. And I'm not advocating for or against this bill. I just want to make that very clear. I remember when I decided to take some classes at Georgia State, I had to get an MMR vaccine because Georgia State required it of everyone. And I called up my physician, been going to for many years. I got sent to a public health department. He didn't have it. No physicians. This year I decided, okay, it's time for me to get my flu shot. He had it earlier in the year. He didn't have it then. Again, it was the same thing. Go to a pharmacy, go to public health, do whatever you want. My ex-husband's a dentist. When we've hired assistants and others that are going to be working with patients in the operatory, we have insisted that they get a hepatitis A and B shot, and sent them over to, I think the hospital was giving it, or public health or something to that effect. We paid for it. There weren't doctor's visits. My concern with people that want a flu shot or something like that, and I'm not getting into all the rest of these, is when they go to their physician, and I agree people need to go to their physicians. I mean, no question about it. Checkups, this, that, everything like that. But there's usually a doctor's charge associated, like with state health that many of us are on. There's a charge now. Plus, the other charge. So, whatever. I'm just bringing that up as something that might deter people, might not. Now, again, I'm very much in favor of people going to physicians. My father was a doctor, so make absolutely no mistake about that. But for people that are diabetic or something else, don't they have to go back to their doctor? Aren't the prescriptions only good for so long?
Well, yes, prescriptions have a shelf life, so to speak. They do.
Yeah, so I mean, some physicians will do it every 3 months or every 6 months or something in order to get their patients back.
Yes, I mean, now, I'm going to turn around and be on the opposite side. To the point Dr. Watson was making, you also have patients that are not on maintenance medication, and they need to be seeing their physician anyway. Just because you're not going back to fill a prescription does not mean you don't need to see your doctor. You need to keep seeing your doctor so you don't have to go get a prescription filled.
Okay, thank you.
Representative Henson, I will tell you, since I've been involved in this and personally involved, when pharmacists began to be able to give the flu vaccine, there was a shortage. This went back to the possibility of an outbreak. And what happened is the pharmacist, I think our retail pharmacists, I don't know, Representative Hardin could probably tell you, but the big chains ordered the vaccine in humongous quantities, and physicians could not get it. So we thought we had a shortage, and they were wanting to make sure that pregnant women past a certain stage could get it, elderly people, that high susceptible people could get the vaccine, and physicians could not get it, and so that in time to do that. It may have been the same for small retail pharmacies that didn't order huge quantities, but there was a shortage of it.
Well, I was talking about this year,
Okay.
not that one. There was a shortage.
But they still order a huge amount of it, and they get first preference. So on that one, the availability becomes a problem. Representative Hardin.
Thank you, Madam Chair. And just a little bit of background. The pharmacists have always been authorized by law to administer vaccines. They administer medications. And we're doing so in the Medical Care Foundation created a Georgia Immunization Adult Coalition when I was head of the Georgia Pharmacy Association. And basically that coalition got together because of the fact that Georgia was 49th in the nation in influenza vaccines. Within 1 year after putting that in the pharmacies, we dropped to 43rd. I haven't kept up with it since then because that was about the time I was leaving the association. But I do know that the access was a major factor, and it greatly improved our vaccination rates on influenza. The other point I would like to make on that is that I think at this point in time, we have authorized school-trained personnel to administer epinephrine, did we not? And also authorized school-trained personnel probably to administer the insulin if needed to children in schools. We were looking out for that, to have that access on emergency needs. So I think, this is a thing that has been good for public health, and the access is a major factor, maybe not in the metropolitan areas, but in the rural areas of this state. Access is a crucial factor, and in the areas that I represent particularly, and I appreciate the opportunity to say that.
Okay. Representative Hardy, are you not, with the way you've been able to administer medicines is by prescription? The physician gave
No,
you
in fact, that's why, in the incident you mentioned with Governor Perdue declaring, pharmacists were already administering the vaccine from the Medical Care Foundation's coalition group, but the law said they had the right to administer, that they were challenged on it, and so, that was stopped. But Governor Perdue saw the need to get by that critical time, and he issued an executive order basically that said that they could continue until we changed it.
But right now, the way the law stands, if a physician sends you a prescription,
right,
you can administer any of these vaccines if a specific physician sends you a prescription.
Well, I have not been in, I retired before all of this started, so I'd have to ask a practicing pharmacist how all that works.
I believe that is correct.
Is correct, that you can currently give a vaccine if you have a prescription from a physician, so you can do that. Okay, that seems to be all the questions that we have. Thank you, Senator Bethel. Oh, Cindy Walkerson, didn't see it.
Thank you. Senator, thank you very much. This is more of a comment about TRICARE. I'm probably the only one in this room on TRICARE. And by the way, I get very upset when people say, you get TRICARE. No, you earn TRICARE. You do 26 years in the Navy, and so forth. But interesting, not a month goes by that I don't get a offer from TRICARE to have all my prescriptions, all my medicines mailed to me, and trying to steer me away from my local pharmacy. And for what it's worth, it doesn't cost me a fortune, but I choose to go to the pharmacy, and particularly because I'm on Enbrel, which has to remain probably 34, 38 degrees. And it's $2,500 a month. So, but I've been very concerned about TRICARE. I've seen those other things. And one other quick thing, Madam Chair, just the frustration. We were told we do all these years in the military and so forth, and we reach a certain age and we're fine. Well, I got to that age. I got a letter from TRICARE saying that if I had, even though I'm under state health, even though I can have the Coca-Cola company, they said I had to sign up for Medicare A and B. I am not allowed to use Medicare A and B, but I have to sign up for it. And because of my income, I have to pay $300 a month for insurance that I can't use. It's very, very frustrating. And so I just appreciate all the efforts to try to help patients.
Okay, thank you. Okay, that's the last question. So I'm seeing here other questions for. Thank you very much, Senator.
Madam Chair, with your permission, I don't generally like to leave when my bill's in the committee, but Chairman Goggins is trying to get House bills out of insurance and labor.
No.
Could I go there and come back? And if y'all are still
Sure.
here, I'll be glad to sit.
Sure.
But I don't want to be disrespectful to the
No.
committee, but I want to move bills too.
We
So.
don't consider it disrespectful,
come
but
back.
thank you for
Thank you.
asking. Okay. Right. Okay, we have several people that want to speak. Mandy Reese, who's married to a former representative. Miss Mandy, how's your husband?
Okay, I'm Mandy Reese. I'm a PharmD. I'm assistant professor at Philadelphia College of Osteopathic Medicine School of Pharmacy on the Georgia campus. Thank you, Madam Chairman, for having me today and allowing me to speak. I am coming to you from the aspect of having been a trainer, a faculty for the American Pharmacists Association immunization training program. I've been a faculty for this program for 10 years. I feel like I'm an expert in immunizations, having taught this for 10 years and keeping abreast of the latest updates in immunizations in the last 10 years. I would also like to share that I currently do, as part of my university duties, spend half my week in an internal medicine, family medicine in Gainesville, Georgia with the Longstreet Clinic. I currently work under two protocols with two different physicians. I manage a gestational diabetes clinic under the protocol of Dr. Ross Jacobson. I initiate insulin pump starts and adjust insulin therapy under the protocol of Dr. Philip Marler with the Longstreet Clinic. So I do want to share that I am experienced with protocols with physicians. So what I really want to talk about are two major points. One is the access to care. And in the program that I actually teach that's published by the American Pharmacists Association, I want to share a couple of statistics with you that to me are rather frightening that do say there is an issue with access to care and patients getting vaccines or immunizations. And the first is from the National Interview Survey of August 2010, and it states the percentage that of folks who qualify, it's for folks who have received a tetanus vaccine in the last 10 years that are of the age range 19 to 49, only 63.1% of those folks have actually gotten vaccinated. In the folks in the age range of 50 to 64, it's 62.8%. In the age range of greater than or equal to 65 years old, it's 52.8%. And of the Zostavax vaccine, when it had the indication of only 60 and older, only 10% of patients who qualified for this vaccine actually received the vaccine, so there is a need. I want to point out, well, you know, what's the big deal with vaccines? So like the gentleman on the committee, the physician mentioned, it's about patient care, and yes, it is about patient care. I want to reference an epidemic that has actually happened in California. I know it's not in Georgia, but it is in California, and it's pertussis. Pertussis is whooping cough. It actually affects children under the age of 5. Adolescents and adults are the ones who serve as carriers for this particular disease, and we know that the reason this epidemic happened is because the adolescents and adults were not getting immunized. I would like to point out in 2005, the cases of pertussis were at 20,615, and it's varied between to 2011, 12,852 cases. That is a vaccine-preventable diseases. We need to increase access to care. So I just want to provide some statistics to show that. The second area that I would like to kindly speak of is the actual training program that pharmacists go through. And I've been teaching this for 10 years. And I actually teach in the pharmacy curriculum as well. And I'm a certified diabetes educator as well. So I'm very well versed. I want to point out in our immunization program, not do we just teach technique. It's simply not enough in a training program to teach technique, but we teach the pathophysiology, the clinical presentation, all of those things of vaccine preventable diseases. In addition, we also teach, of the vaccines, we teach the schedule, we teach the adverse effects, we teach, also an important fact is reporting all adverse effects of vaccines to the VAERS system, which is the Vaccine Adverse Effect reporting system. Pharmacists are taught that you must report any adverse effects that are seen with patients that report that. Also, we teach patients how to respond to emergencies. We teach to activate the emergency system. You always call 911. You never, ever vaccinate if you do not have epinephrine on hand. Big, huge no-no. Pharmacists know that, and they know that they're not allowed to do that. Also, we train on following the protocol in the GRITS program, which is the Georgia Registry of Immunizations, Transactions, and Services. It's a legal requirement here in the state of Georgia. If you give vaccines, you must enter this into the database. So that's not something that's been around for a while. It's a legal requirement. So that gives you a snapshot of what we all talk about in the program. So we're not just talking about how to administer vaccines, but we're talking about lots of additional things as well. And I also want to point out just real quickly, in the protocol, it spells out, and we teach this in the program, what screening questions must you ask a patient prior to vaccinating. And we go through a series of screening questions, which are actually here on the protocol. If any of the committee members would like to look at it, I've got it here. There's also specific screening questions that we teach. If you're giving a live vaccine, you have to go through a series of specific screening tests, specifically pregnancy, immunocompromised. Are you allergic to neomycin or gelatin? There are a series of questions. So it's a very methodical, well thought out program. And again, it's about access to care. And working in a physician's office, I do work with physicians directly. They sign off on all the things that I do, and they trust me as a pharmacist, and they trust the care that I provide. And with that, I just wanted to come to you, share my passion, share the training that we do provide pharmacists, give you exact stats that there is a need, and I humbly thank you for allowing me to speak today.
Thank you very much. Any questions for the presenter? Pardon? Dr. Watson.
Yes, sir.
So the database, I presume, is what the senator was talking about, was the GRITS program?
Yes.
Okay. And that's for children?
It's all immunizations here in Georgia. We have been taught, and here in the actual protocol, it says for all vaccines administered here in the protocol, it must be entered into that database within 15 days. It's legally required. And I actually talked with the Georgia Department of Public Health prior to teaching this program a few years ago when this issue actually came up, and they told me for vaccines that are administered here in Georgia that we have to enter those into the database, and pharmacists have been doing that. And I've been told by the state that that was a legal requirement.
Yeah, it's interesting to note that, I was researching this bill, that one of the biggest complaints was from the pediatricians, which the GRITS program is primarily, that was the reason that was developed, because of multiple impositions thereof relating to pediatricians. But they were getting calls from pharmacists to enter the vaccines that they had given into our GRITS system.
Well, I'll tell you personally, I experienced this. I'm not going to say where my child is a patient, but I've also worked in public health as well, with immunizations actually in public health, District 2 Public Health with Dr. Dave Westfall. My child was going to public health to get a vaccine that she needed, and I was appalled to go into the GRIT system and find that her vaccines by her pediatrician had not been entered into the GRIT system. And that was not a pharmacist, that was a medical practice that did that, and my own daughter's vaccines were not entered into the system. So that was my personal experience. And I think that the system is designed to maintain community. And I'll tell you, I work with the Long Street Clinic. Our Oakwood office is for family medicine, internal medicine, is seeking the recognition of the medical home. And there is discussions on the national level of including the pharmacist into the medical home, because healthcare is about a team now. Yes, I totally agree, Dr. Watson, the physician is at the head of the team, okay? And ultimately the patient is, because ultimately the patient's going to decide when they walk out that doctor's office, what are they going to do from day to day? Okay, ultimately the physician is the head of the team, I give that. But your nurse practitioner, or your PA, your pharmacist, your exercise physiologist, if you're dealing with a diabetic patient, diabetes educator like myself, we're all part of the healthcare team, and it takes a team to do that. And a pharmacist is a part of that healthcare team in the medical home, and it's being discussed on a national level. And so, again, this is to work along with the physicians in the community. This is not to take any turf from anybody. This is to, man, let's draw some patients in, let's get them vaccinated and say, you know what, have you been to your doctor in the last 6 months or the last 12 months? So let's get them into the healthcare system.
I agree with you 100%. And you know, in pharmacies and PharmD students now do rotations in hospitals and residencies, and I think it is a team approach, and we should all be working together. You know, but on the other hand, I mean, it is a scope of issue. It is an aspect of the care that. You know, when I boil it down to what's going to be best for the patient, I still, you know, have a hard time looking at that from a perspective about a physician's office and getting vaccinations. I applaud you working with Longstreet. I think they do a wonderful job. And I do think that it is a team approach,
Yeah.
and ultimately the patient is the person we're doing this for.
And I think you and I have two different arguments, but at the end of the day, I think we both want the patient to have what's best. And I can tell you, as a pharmacist, I'm passionate about my patients. I've taken jobs where I didn't make a lot of money. Money's not been my driver. And I'll tell you, this bill, teaching pharmacists to have patients get immunized, it's not about the dollar. It's not about power, and it's not taken about, it's not, and I tell you respectfully, when we present this piece of legislation, it's not about taking scope of practice from anybody. It's about providing immunizations to patients, getting that into the grid system, coordinating with that with the physician, communicating with that physician that you provided that, and you have to ask those screening questions beforehand. Never make assumptions, and I'll tell you, I teach that whenever I teach the program. Never make an assumption about a patient. First of all, two things. If you don't ask screening questions, you better not give that vaccine to a patient. Two, if you don't have epinephrine on hand and you're not not CPR certified, it's BCLS certified, you cannot give immunizations as a pharmacist here in Georgia. And I will tell you, physicians that I work with wholeheartedly support this with the Longstreet Clinic. The physicians I actually work with support this. With that, I appreciate you.
I have a question.
Yes. Oh, yes, ma'am.
Okay, do you actually work in the clinic with the physicians?
Yes.
Okay, so you are actually in a clinical practice with physicians on hand?
In one situation, I am. In another situation, I'm not. In the other situation with gestational diabetes, I'm at the local health department, but the physician is not there. I'm working strictly under a protocol. He's not there at all. He's across the way at the office, but the physicians actually that I work with are not comfortable managing gestational diabetes, so I actually have a protocol that I work under with them that they've signed off, but they are not there with me now.
Okay, so you're, just a question, you are doing gestational diabetes instruction?
And I initiate insulin therapy, address therapy, all of that.
Well, since you're teaching that at the medical school and all, do you foresee that as another bill that you would bring forth so pharmacists could do that in the offices, do it in their pharmacies?
Realistically, I would. There's something in North Carolina called the clinical pharmacist practitioner, and what it is it's pharmacists working under protocol of a physician. Usually it's actually directly in the physician's office. The majority of the time they're actually in the physician's office, work in a similar role to a nurse practitioner or PA, but they have to have additional training. So an entry-level degree in that scenario is not enough. They have to have board certification in pharmacotherapy. So there is some additional requirements, and they are directly working under the protocol of a physician, but usually they are in the physician's office. Yes, ma'am.
Thank you very much. Thank you.
Thank you.
President. I was going to say this in the end, but Representative Harden, you had a question?
Lee, Mandy, thank you very much for your presentation, and I think one of the things that you brought out probably as a sidelight, is that pharmacy records have been computerized for some 35 years.
Yes,
now.
sir.
And so therefore it is easy for the pharmacist to enter the data into the system.
Yes,
Where
sir.
it's needed.
Yes, sir. And that data, I will say this, those of you who are, when we talk about prescriptions, those only have to be maintained for a certain period of time. For any pharmacist that does influenza in their pharmacy, must maintain that record and that screening form indefinitely. They cannot get rid of it at any point in time. It is a part of the permanent medical record. And we do teach that you need to communicate that with the physician, but again, the protocol, we define that with them.
Okay. Thank you, Mandy.
Yes, ma'am.
I've known Mandy since she became a Reese, and I know her passion. I won't read the whole letter. I hope you will read to the committee members, and I'll be glad to give it to other people. What I put on your desk, it's from a pharmacist, and I just will read a thing. She's as passionate as Mandy was, but she couldn't be here because she's working. She asked that her identity, she is a retail pharmacist, not be identified. I did not put on here who, especially, she didn't want to identify too, but on the second variant, if you have ever witnessed the multitasking and general fast food drive-through mentality in a retail pharmacy, especially in large chains, I fail to see how already overburdened pharmacists would be able to meet all the demands of daily prescription filling, in parentheses, in 15 minutes or less for a waiter in most chains, overseeing an auxiliary staff, patient consultations, etc., and be involved in multiple vaccine protocols. If that is the case, it seems as though it would be opening a Pandora box for the big chain pharmacy retailers to add any and all vaccines for their list of provided pharmacist services. As you know, it goes on and on. I think that this is one pharmacy that is just as passionate as Mandy is. In fact, she's called 3 times today, and sorry that she couldn't be here. So I promised her I would at least put the letter out and I would bring part of it to your attention. Dr. Batt. And I appreciate the members that are sticking with us. No. It's a hearing.
I'll just introduce him.
Okay, go ahead.
Good afternoon. I'm Rebecca Greener with the Medical Association of Georgia, and I'm pleased to have here with me this afternoon Tom Batt, a physician practicing in the Alpharetta area. He's going to give a little bit more testimony on why we are opposed to Senate Bill 288.
Okay. Dr. Batt, welcome.
Thank you. Good evening. Sorry to keep y'all here this late, and I don't have any prepared remarks. So I did get to attend the session today and watch everybody reading on the last bill they passed, and I just got invited to this, and you can tell that I'm not here as a legislature, or I'm actually not here as a lobbyist for MAG or MAA. Otherwise, I'd have worn a black suit and tie. I'm here as a doc. And I've been a family physician since 1988 in the state of Georgia. I practiced up in North Georgia where there are a bunch of cows. We're now a 15-man family practice group up in Woodstock, Cumming, Suwanee, Alpharetta. We saw 130,000 people last year. So we see lots of patients. And we think we do a good job. Last week, we became a patient-certified medical home. So we were actually the very first primary care clinic in Georgia who's multi-site, who's not owned by a hospital, who's not owned by a medical center or an academic center, which is a patient-centered medical home. And I just bring this up to hopefully share with you my perspective. It's not coming from a suit. It's actually coming from a doc who's done this for 25 years, who struggled to try to be on the cutting edge in a part of Georgia that was very rural when I came to Georgia in 1988. The pharmacists and us, as well as the nurses, PAs, other healthcare givers, hospitals, all come in these rooms, I think, and argue about turf battles all the time. We actually work very collaboratively together. Pharmacists and physicians should probably even be more collaborative, which is why I hate when this is all structured in a turf battle sense, because it's really not. This is ultimately about patient care and treating the population we have in Georgia. Okay. Y'all have talked a lot about patient-centered medical homes. I did it. Let me tell you about it. It's not easy. It costs money. NCQA is a racket. It's making money on doing this. I heard some people talk about JCO in the last open session there about how they certify hospitals, and now there's another competing organization to do it. These are companies that make money. We hope they help improve care, but they're there to make money. There are only 120 physicians in the state of Georgia that currently have the designation of a patient-centered medical home. I pulled up the website before I came here. Longstreet Clinic, which the last speaker spoke about, is one. And they've obviously done a very good job to get that designation. The other centers are associated with mostly the medical schools that are in Georgia, in the Rome area and the Augusta area. So they've done a very good job. And part of what you see in the medical centers is a collaborative effort to build a vertically integrated delivery system. And you guys are going to be hearing all this from the federal legislation and some of the arguments, I suspect, next week, talking about ACOs, accountable care organizations, and CINs, clinically integrated networks. We're all talking about how to collaborate care and make it better. And I heard a lot of that today, is why I sort of wanted to remark on it. I wish I could answer every question that I heard today, but I don't have the time to do that. But everybody in this room that talked about other things, talked about things that were very, very important. And the 2 or 3 things I heard that were super important were, we need to improve the delivery of health care in Georgia. We need to improve the public health care delivered in Georgia. We need to improve the primary care health care in Georgia. Instead, we're talking about immunizing our citizens in a Kroger's or a Publix or a Walgreens for vaccines, generally for communicable diseases. I will tell you, when I heard that this was going on just a few days ago, I will tell you, it makes no sense. And that's the short end of it. And I don't mean to be disrespectful, Madam Chairman, or to my representatives here, or my collaborative people that I work with in the healthcare industry. It makes no sense. We're comparing apples to oranges when we talk about flu vaccines, and when we talk about hepatitis vaccines, when we talk about pneumococcal vaccines, when we talk about meningitis vaccines. And hopefully in my lifetime, we'll be talking about the HIV vaccine. The only one time I actually spoke before the House of Representatives was the week that we discovered what the HIV vaccine was, and I happened to be doc of the day. I was very, very young. And the legislature was voting on whether to make it mandatory testing. And I actually happened to be in the House that day, and they asked me to come down to the well and speak on it. And of course, it would have been a multi-$100 million effort to test everybody in Georgia at that time with a very expensive test. And the legislature came to their sense that AIDS awareness was more important than just testing. There's a lot more important things to do about immunizing our population than doing it in the back of a Kroger's. The apples and oranges of comparing flu vaccine to hepatitis vaccine is just not fair. Flu vaccine we give once every year. We give it to 60 to 70 million people in this country. And if you think about it, we've expanded the population that we immunize. Everybody in this room remembers when it was only above 65. Everybody in this room remembers when it was a sick person. Not everybody in the room, the young guys back there laughing down. Us old guys remember this. I remember when we didn't vaccinate pediatric patients, okay? So we try to vaccinate 1/3 of our population in America in about a 6-week period. There is a good reason to try to expand the workforce to do this. I have the opportunity to give vaccines to adolescent kids and young adults only once generally. We don't revaccinate for all these diseases. We give it once. This sometimes is my only chance to interact with these people as patients. I could go through all kinds of anecdotal stories for you and tell you, every one of these pharmacists in here is qualified to give those vaccines. So maybe I don't represent MAG so well. I could train every one of you guys before 8 o'clock tonight to give vaccines for me in my office. Every one of you is qualified. Does that make it appropriate? And I don't think it does. You've got to look at the setting. You've got to look at the interaction. You've got to look at how we treat patients. And part of treating patients is doing what we do at the patient-centered medical home, making the patient the center of the visit. We do have patients that come for vaccines only, but oftentimes they'll get the nurse or the physician in the room and other things will occur. Most likely, when we're talking about hepatitis vaccines, what do you think I'm going to talk about with somebody in their young 20s who's come in here and wants to talk about getting AIDS tested, getting hepatitis tested, and getting vaccinated? We're going to have a very good and frank encounter. Do you really think that's going to occur in the back of a Publix? Do we think it's appropriate? And none of us do. And if we choose not to have that and just to give Hep A and Hep B vaccines to people, that's fine. You can increase the vaccination rate perhaps, but I don't think we've reached our goal to the citizens. And really, that's what we're here for, right? Am I missing something? Are we here just to raise some statistical value, or are we actually here to improve the delivery of health care in Georgia? And that's what I'm here to speak about. So I don't have prepared remarks. I could talk forever about a lot of the things I heard that I find completely inaccurate, but comparing influenza to these other vaccines is hugely not fair and is incorrect. Most of these other vaccines are given once in a lifetime or once every 10 years. We are getting very good in medicine. What these guys do in pharmacy, and the guys that come in biochemistry, and the guys that go to Mercer and they study biopharmacology, is they're helping us invent new drugs constantly. Yesterday I visited a compounding pharmacy. You should see these 5 pharmacists working away, actually making medications for my patients. This is what they're trained to do. I would trust any of these guys to walk in my office and give vaccines. Right now, I learned just recently that I could write a prescription and send it with a patient, and they could get that vaccine at a pharmacist who I collaborated with. But what we're trying to do is to blanket give vaccines to people I haven't collaborated with, who I'm not comfortable with. Ultimately, these are my patients, okay? I know the insurance companies say they're theirs, and maybe now we'll say the drugstores will say they're theirs, and I'm sure the state legislatures might say they're their patients because they live in Georgia. But ultimately, when things go wrong, guess who they call? How many people think that we got a phone call in the last week from a pharmacy because a patient had a side effect to something? Happens every day. And we expect them to call us, so please don't take that wrong. When they have a swollen arm, or they get hurt, or they get the wrong dose, which happens sometimes, they call us. What do you want us to do with your patient? They just got the wrong dose. Sorry. So we get stuck with it. If a patient blacks out or passes out, does anybody in this room think that people really don't have vasovagal responses to needles? Somebody was talking about being a TRICARE person, and I thought about the movie Pearl Harbor, where the patient got stuck and passed out. It happens 3 to 4 to 5 times a day in our offices. Do we call 911? Only when it's appropriate. So in the back of a pharmacy, we'll be calling 911 a lot. Does anybody know what it costs to take an ambulance to an emergency room for somebody who just vasovagal? Yeah. And I think everybody in this room has a guess of what it costs. We call ambulances too, but that's not before we assess the patient, usually do an EKG, auscultate the patient, put them in Trendelenburg. I'm a big believer is you put IV fluids in them, because half the time they're hypoglycemic because they haven't eaten for the last 2 or 3 hours. And we treat them, and then we get them on their way and send them home. In the back of Kroger's, what are we going to do? It makes no sense. Sorry I talked so long. Thank you, Madam Chairman.
Thank you. Are there any questions for Dr. Beth? Okay, no questions. Thank you very much for coming. We have a couple more people. We'll try to end it by 6:15. I'll give you a little, I think, over. Lisa Chapman. It's about 5 minutes, okay?
Yes, ma'am.
Then no?
That's perfect.
Okay.
Thank you, Representative Cooper, for allowing me to speak favorably on Senate Bill 288. I am a practicing pharmacist in the state of Georgia. I've been practicing for 10 years now, and I want to talk favorably to you about pharmacist-based immunization delivery. I have had the opportunity and privilege to vaccinate thousands of patients in the state of Georgia, and I just want to give you just a taste of what we do and to augment and echo the remarks that Dr. Reese made previously. We do follow the ACIP, that's the Advisory Committee on Immunization Practices guidelines. So we have created a high standard of care in the vaccination of our patients. We complete a thorough medical history before we vaccinate anyone. And I do feel that we have a unique opportunity as pharmacists, because I get to see those patients on a monthly basis, and looking at their medication profile, I'm able to identify certain vaccinations that these patients are indicated for. We also do a thorough contraindication and indication profile for our patients, and we also provide post-vaccination care guidelines. I will say, last time I received a vaccination in a physician's office, I did not receive a vaccine information statement. I did not have my immunization reported to the Georgia Immunization Registry. So I wanted to just point out that we have taken that information and we have instilled that in all the pharmacists that we train. We have established protocols with 15 physicians in our practice setting that we work with across the state. And I would like to point out that the protocol that we do use was approved by the Georgia Composite Board of Medical Examiners. So it's the approved protocol that they have issued for us to use. We do a very good job to provide two-way communication between the pharmacist and the patient. Now, granted, not all patients have a physician, but there are those that do, and they ask us to submit their information to that physician. We want to provide that information to the patient's medical chart. As Mandy said, we do have proper training. It's through the Accreditation Council on Pharmacy Education, and it's a CDC-approved course. It's 20 hours of continuing education, but that's still not enough. As pharmacists, we need to be up to date on a daily basis about medications, and we also make sure that we have proper training when new vaccine indications are released. I would like to point out that pharmacists are one of the most trusted healthcare professionals. When I working in a pharmacy, I did have opportunities. My store closed at 11 o'clock at night, and I got lots of calls at night because folks didn't want to bother their doctor and how to treat certain things. Yes, I'm not diagnosing, but if it did come down to it, I did refer that patient to their physician and also to refer them to the nearest emergency facility if necessary. This is, again, about increasing the access for care, and as a healthcare provider, we're just seeking better opportunities to provide that patient care needed. So I would just like to ask the committee to please consider the passage of Senate Bill 288, please.
Okay, Lisa, thank you for coming. Are there questions for Lisa? What kind of pharmacy do you work in?
I'm a community pharmacist with Kroger Pharmacy.
Okay. Thank you very much. I will say we had a bill a couple of years ago, and when you're saying you have time to do all of this training and everything, the bill was to have pharmacists notify the physician with a phone call if they changed an epileptic's medication either from brand necessary to generic or generic to brand, and also for people who had had transplants from brand necessary to generic or generic back to brand, whichever way. And one of our pharmacists killed his own bill because that was added onto it. And one of the things was the lack of the time to be able to call the physician to let them be notified on that very important bill. I guess it's because if you're an epileptic and you have a seizure, take your driver's license and all, and if you are a transplant patient and something in the different way they've held together the generic may cause you to have damage, I just personally don't understand how we've gone from not having enough time to do that to now having a time to this very thorough information and immunizations. Like that.
Well, just to speak to that, I can't speak to other pharmacists' practice, but I do know that it is very, very important, and there's lots of things that we have to do in a given day, but the most important thing is patient safety. So we do have to take the time, delegate to pharmacy technicians to worry with insurance claims, things of those natures, but things that such as contacting the physician's office, sitting down with that patient, that's my responsibility as a licensed provider in the state.
Thank you very much.
Thank you.
Maybe questions. Okay. Kidd, Representative Kidd, you had a question.
What I was going to ask, Madam Chairman, is I read somewhere not too long ago that the ultimate goal of the pharmacists, and this might not necessarily be the Georgia pharmacists, but the pharmacists, was that for the physician to diagnose and the pharmacist to prescribe. allegedly because the pharmacists know more about drugs that are coming out daily than the physician might. But I didn't know if that was the ultimate goal of the pharmacists in Georgia or not.
Right.
Sir, to my knowledge, it is not the intention of pharmacists to prescribe in our state.
I will tell you, Representative Kidd, that that was put into a bill for pharmacists this year to do therapeutic substitution, and a step toward that. And that would mean, if any of our members don't understand what that is, they wouldn't just give a generic that was exactly the same thing as the one ordered. They would be able to, from like a class of antibiotics, decide to give an antibiotic in another class, and a totally different type thing. That was in part of one of the pharmacy bills. So Representative Kidd, don't know what the intention was, but it was in one of the bills. Thank you. Might be news to you, probably. Thank you very much. And last but not least, Dr. Dorr, is it Dorr? Thank you very much for waiting this out. Okay.
I'm a recently retired primary care general internist. I worked at the VA here in Atlanta. And I'm also the chair of the Healthcare Policy Committee for the Georgia chapter of the American College of Physicians. The Georgia chapter of the American College of Physicians is arguing against this bill. Recently, Jacqueline Fincher, our governor, sent Chairman Cooper a letter, and I'm not going to read it. I'd just like to highlight a couple of things she emphasized, and then I'd like to speak to a couple of these points from my personal experience. First, we think that this bill will further fragment primary care, when in Georgia, we really need to strengthen primary care. It'll be great when more physicians are involved in patient-centered medical homes. We are 1,000% behind that. Right now, most of the primary care physicians in Georgia aren't part of that, but at least they're providing comprehensive, continuous, systematic care for their patients. Secondly, she mentioned a number of things, but the other thing was a real concern for administration of live vaccines when it's important to identify contraindications and adverse reactions. And I'd just like to speak personally. In the last several years, I've personally taken care of multiple patients who were immunocompromised and for whom there would be an absolute or a relative contraindication to Zostavax, one of the live vaccines that's been discussed today, to prevent shingles. Okay, these patients included patients with many types of cancer who were on chemotherapy at the time. It includes many patients with kidney transplants, patient with liver transplant, patient with bone marrow transplants, who were on really strong immunosuppressants. It involves HIV patients. It even involved patients with immune diseases, autoimmune diseases, patients with severe lupus or severe rheumatoid arthritis, who were not only on prednisone, but who were on antimetabolites. And in all of these patients, Zostavax is either absolutely or relatively contraindicated. And it's not clear-cut. They're not all absolutely contraindicated. It depends on the strength of the immunosuppression. You know, with a patient with HIV, you track the CD4 cell count level, you track the viral loads. These aren't simple things. They're very complex, single dimensions in very complex patients. I'd like to just read a list of the oral live or the live vaccines that are being given today, the kind of things that are discussed in this bill. They include influenza, measles, mumps, the polio oral vaccine, rotavirus, rubella or German measles, smallpox, typhoid, varicella or chickenpox, yellow fever, herpes zoster, Zostavax for shingles, or BCG for tuberculosis. Virtually all of these live vaccines are absolutely or relatively contraindicated in immunosuppressed patients. One of the earlier people that testified said they take a thorough medical history from the patients before they prescribe this. One of our great frustrations in primary care is that most patients find it difficult to remember all their diseases, and we make a real effort to really confirm all that. Patients who we then follow and understand over a long period of time. The second point I want to make is that there are many parents in America now that are against immunizations because they think it will do more harm than good. This is this morning's USA Today, front page. One of the two headlines is, measles outbreak could hit the US today, this year. And the reason is that we have thousands and thousands of children in this country who have not received immunizations. And a lot of Americans are going to London this summer, to the Olympics, or they're going to the World Soccer Championships in Poland. And then they're going to come back here, and they could infect people, and we could have a measles epidemic in this country. Okay, they're not going to be educated in the pharmacies about this. That's why it's important to encourage every person in Georgia to see a primary care physician frequently, whether it's about their children or it's about themselves. Several weeks ago, there was an article that, I think it was in USA Today too, it might have been the Atlanta Journal-Constitution, that talked about the risk for polio in this country again. Because parents have been against vaccinations for their children. I've been to India twice. Poliomyelitis is endemic in India today. There are many epidemics. Thousands of people fly daily between that subcontinent and the United States of America. Again, they're not going to get educated outside primary care offices. We need more newspaper articles like this, but we need to get all the people of Georgia into primary care periodically so they can be comprehensive in what they do. When a patient came into my practice, which was at the Atlanta VA, we didn't just ask about influenza and tetanus. I think it's, as Dr. Watson mentioned, we ask about colonoscopy, we ask about depression. In the VA, we asked about PTSD. We go through 30 different healthcare screens, and we're rigorous about making sure that people's blood pressures are controlled. If they're diabetics, their A1Cs are controlled. It's not just immunizations. But by coming into the office, one thing triggers another. I can't tell you how many times one of my nurses came up to me, and we're both in the same office, and said, you know, this patient really is quite sick. I'm not sure that the immunization should be given or not, and we dealt with it. I'm going to stop there. These are our concerns. Primary care should not be further fragmented, and I really think powerful things like oral vaccines should be given in the presence of where physicians are present. Thank you.
Questions for Dr. Dewar? All right, Representative Harden.
Yes, and I appreciate everything you're saying, but I did want to say, and with all due respect, that no pharmacist that testified today said that they took a medical history before they prescribed a vaccine. All of these vaccines under this bill, as they are now, will be under protocol from a physician and only at a physician's orders. So we need to begin to work more together. I have been involved in many projects when I was with the Pharmacy Association, where we put physicians and pharmacists and nurses and diabetic educators together and dramatically improve the outcomes with diabetics, but also reduce cost. And I think what we're doing here, instead of trying to pull together the healthcare providers to increase or to improve the quality outcomes that our patients have, is we become involved maybe in these types of things. And I hate that, because I too am passionate about the health care that we have in this country, and we have got to begin to work together to see that it works, and I hope we can get that done. Thank you, sir, for your presentation.
Representative Harden, just to clarify though, and I think it is a good thing, like Mandy said, when you can work in that kind of setting, and I know you've worked in a clinical setting, but in this bill, it would not be where you know the patients. There would be a standing order, and they could give up to 10 patients or something like that without ever knowing those patients, correct, in this bill? So there would not be the real physician's involvement in knowing the patients, correct? I believe it's that way.
Really, under the protocols, it should be that physician involvement in knowing the patient. And I agree, we need primary care homes. And in my area, where we're very rural, we have clinics in small towns throughout my counties where they are advanced practice nurses that work as the primary, and really the only access to primary health care, because the patients in those communities don't have the wherewithal to go to maybe a larger center to get their treatment. So, but they do primary advanced practice nurses operating under protocol with physicians, and pharmacists operating under protocol with physicians. A real team effort is needed to help us improve the quality of those patients' care, and that's what
Well, but Representative Harden, just for clarifications for other members, when a nurse works under a protocol, there is a limit of the number of nurse practitioners that can work under a protocol, and they are dealing with that physician's patients, and they communicate with that physician. It's my understanding, well, having read the bill, in this situation, it would be a protocol from a physician who would never know those patients. And that, I think if you'll read the bill, that is, and there's, so it's not that actual nurse practitioner communicating with a doctor and about the patients they see, but a sort of blanket, you can, under somebody's protocol, see whoever walks through the door for it. So I think if you read the bill the way it's written now. Thank you very much to my committee. Thank you everybody, to the presenters, and thank you for being so patient. We are adjourned. Thank you, Dr. Dorr. Okay. You're welcome. Thank you very much.